So we believe that the Alzheimer's disease neuroimaging initiative has been successful. And we believe that it's been impactful, not just because of 4,000 papers, but many of the clinical trials, including, for example, Biogen's trials on aducanumab, as well as Eisai's trials and the Roche trials and the Lilly trials on monoclonal antibodies, some of which have now received breakthrough designation. All of these companies have used ADNI data over the years to help design their trials, perform statistical power analysis, and so forth. So the ADNI has had a big effect on the field, and there's been a lot of, you could say, validation of the biomarkers. For example, much of what we know about how amyloid PET scans change over time comes from the ADNI data. And now that blood tests for Alzheimer's disease, including measurements of amyloid beta 42/40 and various species of p-tau, are being developed by many different companies, the ADNI, huge ADNI repository of plasma provides an opportunity for us to, first of all, provide samples to those labs and companies that want to test them out. And secondly, it allows us to compare the results because the same samples are being given to multiple groups. So that's all been a success, I think. What has been our biggest limitation? It's been that the majority of our subjects up to now have been well-educated, relatively affluent white people, and that our ability to recruit Blacks, Latinos, Asians, and other people who are underrepresented in research has been difficult. We've up until about 2 years ago, we had about 10 or 11% of our participants were non-white. And in the United States right now, if you look at the census figures of people over 60, it's something on the order of 40% of the population is not Caucasian. So we're way off. Furthermore, the average education, maybe I had that wrong about 40%. Maybe it's more like 30 or 35% non-white in the United States over 60. It's the education that's another big limitation. Our average education in ADNI is about 16 years, meaning 4 years of college is the average education of ADNI participants. That means that half of our participants have graduate degrees. Okay, I have an MD, so I'm pulling up the average. We have very few participants with only a high school education or less than a high school education. But if you look at the census figures of the United States of people who are over 65 or over 60 years of age in the US, I believe it's about 40% of the population only has a high school education. So the education level of the people in ADNI is very different than the general population. So basically the ADNI sample, and I should say that the ADNI sample is not unique. Most clinical research, if you look at the demographics, are largely relatively well-educated white people. It's not just in the Alzheimer's field, actually. It's in all areas of research. And there are many reasons for this, but fundamentally, to be in research, a participant has to volunteer. And who volunteers to be in research? Well, it's people, first of all, who are knowledgeable about research. They're educated. They're interested in research. They want to participate. And also about people who are not suspicious of the research establishment. So, for example, among Black people in the United States, we had a horrible experience called the Tuskegee scandal many years ago. This was in Alabama, where Black patients in a syphilis trial were denied treatment. They were not told that they had penicillin was available to treat their syphilis. They were allowed to have progressive untreated syphilis, and many of them died from this. This was a horrible thing. It was discovered in the late 60s. It was all in the newspapers, and Congress passed legislation requiring ethics board, what we call the Institutional Review Board, the IRBs, all came out of that terrible scandal. But if you talk to African Americans in the US, they're going to, they all know about Tuskegee, and they basically are suspicious of the medical establishment. Many of them are. The other reason why we have underrepresentation is because in the United States, we really have healthcare disparities. That is, that poor people don't get the same medical care that affluent people get. And in the United States, more people of color, African Americans and Latinos, are of lower education. They have lower socioeconomic status, and they're getting less good health care. There's abundant data to support that. So because they're getting less good health care, they have more comorbidities. So there's more, for example, there's more untreated hypertension in the poor population. There's more obesity, more diabetes in the poor population. And those comorbidities result in their being excluded from clinical trials because clinical trials have inclusion and exclusion criteria. And usually the clinical trials have very, very strict exclusion criteria. So they have a relatively clean sample to study for their treatment trials.